So hello everyone, we are moving to the next topic. Topic is bronchiectasis. Bronchiectasis. So first let us see what does this term mean. Okay, I am trying to split this term. Okay, bronchi and ectasia. Okay. So bronchi means it is some airway and ectasia means there is some dilatation. Okay, so in simple terms it is some dilatation of the airway. So putting it into a better definition, bronchiectasis is the abnormal and irreversible dilatation of bronchial wall. Okay, bronchial wall. So that is what is referred to as a bronchiectasis. Okay, alright. So this bronchiectasis, why does this abnormal permanent dilatation occur? So that is what we are going to see. So now we are going to discuss the etiopathogenesis. Why does this occur? Okay, etiopathogenesis of bronchiectasis. This is very important. Now bronchiectasis, you can divide it into two types. Okay, this dilatation you can divide it into two types. You can have a focal bronchiectasis. You can have a diffuse bronchiectasis. Simple. Focal means the bronchiectasis, the dilatation of the bronchi is very focal. Okay, at a particular region only. Diffuse means you are having a diffuse dilatation of your airway. As simple as that. Now this focal bronchiectasis, what is the condition that leads to a focal bronchiectasis? See, focal bronchiectasis could be due to various conditions. There is some focal obstruction, correct? And subsequent dilatation. So this could be due to something inside the bronchi like a foreign body. Okay, it could be a foreign body inside the bronchus causing a subsequent bronchiectasis. Or it may be something else that is compressing onto the bronchi from outside, which may be a tumor, a lung tumor. It may be a lymph node that is pressing onto the bronchus. Okay, so all this will cause a focal bronchiectasis. But on the other hand, you have a diffuse bronchiectasis, and the diffuse bronchiectasis is often due to systemic conditions. Okay, so when you discuss diffuse bronchiectasis, you can divide it again into two. Okay, this again can be classified into two. This could very well be due to infectious causes. It could be due to infectious causes resulting in a diffuse bronchiectasis, or non-infectious causes, infectious or non-infectious. Now, what are the infectious causes of a diffuse bronchiectasis? Infectious causes could be because of say a Mycobacterium tuberculosis, again a very common infective organism in our setting. Okay, so that can very well cause a bronchiectasis, Mycobacterium tuberculosis. You can have other infectious agents which are implicated as well. Okay, so in the pathogenesis of bronchiectasis, you may have organisms like Pseudomonas, H. influenza, okay, Mycoplasma, as well as non-tuberculous Mycobacterium, NTM, non-tuberculous Mycobacterium, especially your MAC. What is MAC? Mycobacterium avium. So Mycobacterium avium also can cause a bronchiectasis. So these are the common infectious causes of bronchiectasis. You can also have non-infectious causes. Okay, very important, non-infectious causes of bronchiectasis. So what are the non-infectious causes? See, you can have certain conditions, okay, which can predispose, like an immune compromised state. Okay, so which can itself predispose to certain infections. Okay, so per se it might be a immunocompromised state. Okay, so example is hypogammaglobulinemia, hypogammaglobulinemia. Okay, and maybe sometimes an infection like an HIV itself. Okay, so primarily it might not be the HIV that causes the infection, but still in an immunocompromised state it can predispose to infections. Okay, so one is immunocompromised state. Then another trigger could be certain genetic causes. Okay, certain genetic causes. And what are the genetic causes predisposing to bronchiectasis? It could be cystic fibrosis, it could be cartaginous syndrome, and alpha 1 antitrypsin deficiency. These are some of the genetic conditions that can predispose. Then you can have immune mediated conditions. Okay, immune mediated conditions that can predispose to bronchiectasis, which includes rheumatoid arthritis. Okay, you can have in Sjogren's syndrome. Then you may also have bronchiectasis associated with inflammatory bowel disease as well. Okay, inflammatory bowel disease. And also understand that the immune mediated bronchiectasis can also be due to allergic bronchopulmonary aspergillosis. So why did I put it under the immune mediated category and not put it under the infectious category? Because this ABPA is nothing but a hypersensitivity reaction. Okay, it is a hypersensitivity reaction to Aspergillus fumigatus. Okay, so that is why I have put in this category of immune mediated. Okay, so immunocompromised state, genetic conditions, immune mediated states. You can also have aspirations. Okay, so aspiration. So when there is a repeated aspiration, micro aspirations, it might not be a large, say, single volume aspiration. It might be repeated micro aspirations. So when such repeated aspirations happen, what can happen is that can again trigger the development of bronchiectasis in that particular individual, because it might trigger indirectly the colonization by organisms. Okay, so these are some of the important causes of bronchiectasis. Okay, important etiologies of bronchiectasis. Now let me tell you one thing. There is a theory that is known as the vicious cycle of bronchiectasis. So what is this vicious cycle of bronchiectasis? Okay, because I have shown you a whole list of etiologies in the bronchiectasis group. So I am trying to tell you how this happens. Okay, how this irreversible dilatation and thickening of the bronchial wall happens. That is what I am trying to tell you. See, what happens is, suppose you have got, say, a trigger. Okay, initially there should be some trigger. So suppose if an infection is going to be a trigger, okay, suppose an infection is going to be a trigger for the bronchiectasis. Okay, that is just a starting point. So when there is an infection, what happens is that locally there would be what? There would be some inflammation. Okay, there would be inflammation of the bronchial wall associated with the infection. Okay, probably mediated by all these inflammatory mediators, you will have inflammation. So when there is an inflammation, that can actually cause what? A destruction in the bronchial wall. Okay, destruction in the bronchial wall. Correct? So when there is some destruction happening in the bronchial wall, would you agree with me that the normal mucociliary clearance would be impaired? Yes or no? So that would impair the normal mucociliary clearance. Normal mucociliary clearance will be impaired. Now what happens when the mucociliary clearance becomes impaired? That can predispose to some stasis of the secretion and subsequent colonization by organism, again triggering this infection. So what will happen? Again there is an infection and subsequent inflammation, destruction of the wall, then there is a dilatation. So this is the vicious cycle of bronchiectasis. Okay, so infection is just a part of it. So depending upon what condition is causing this bronchiectasis, this cycle can perpetuate. Okay, because bronchiectasis, remember, it's not an acute condition. This is a chronic condition. So the disease process has got to propagate. So if it has got to propagate, there should be some factor that drives the disease process on and on. So, okay, so that is what you call your vicious cycle of bronchiectasis. I hope that is clear. So in your exam, it is very important to understand all these etiologies, okay, causing bronchiectasis, both the focal as well as the diffuse bronchiectasis. They may give clinical scenarios as well. Cystic fibrosis, I will discuss it separately. Cartagener's syndrome, you know that this is also referred to as the immotile cilia syndrome. So now you might be in a position to guess that whenever there is the motility of the cilia is affected, the clearance of the secretions would be affected. There will be stasis of the secretions, predisposing to infections. And similar also in alpha-1 antitrypsin deficiency, because there is in alpha-1 antitrypsin deficiency, there is a increased destruction of the bronchial walls by elastase. So the elastase mediated destruction of the bronchial walls occurs, which you have learned in pathology. Okay, so all these are predisposing. Even immune mediated conditions also predispose to bronchiectasis. Okay, all right, so that is very clear. So having understood the basic etiopathogenesis, I'll just take you to the table in Harrison also. Okay, you see this is just a summary of what we have discussed so far. The major etiologies of bronchiectasis. You see there is focal, there is diffuse. Focal we have discussed, and in diffuse you have infections, immunodeficiency, genetic causes, autoimmune causes, aspiration, and also certain miscellaneous causes are there like yellow nail syndrome, traction bronchiectasis like from post-radiation fibrosis. If you have been exposed to some radiation, what can happen is that there can be some destruction of the tissue there and subsequent dilatation. That is a bronchiectasis secondary to a radiation. Okay, and again a small proportion of cases can even be idiopathic. So that is how you will classify bronchiectasis. Okay, so I hope that is clear. Now when the bronchiectasis actually happens, okay, this destruction happens, there are different subtypes of this bronchiectasis, okay, if you can call it that way. Because subtypes, I mean that in the pathology that results from bronchiectasis, you can either have a cylindrical, the types of bronchiectasis, okay, I am trying to convey to you the types, the cylindrical or tubular type of bronchiectasis. That is one type, cylindrical or tubular type. The second one, you can also have the saccular or cystic type of bronchiectasis. And third, you may also have varicose type of bronchiectasis. So these are the main subtypes of bronchiectasis. I'll just show you a picture. So this is the normal bronchi, and this is where the bronchi is dilated. This is like a cylindrical type of dilatation. So the bronchi dilates, the walls are thick, and inside the lumen you might have pus and other secretions. This is a varicose type of bronchiectasis, and the cystic type of bronchiectasis, I am sure with your imagination it looks like a bunch of grapes in cystic. Often the commonest variety that you might encounter will be your cylindrical type of bronchiectasis. Okay, so this much is clear. So after having understood the etiopathogenesis of bronchiectasis, now we are moving to the clinical features. Clinical features of bronchiectasis. So clinical features of bronchiectasis, let me begin by telling you this point, that this is actually a chronic disease process. Okay, this is a chronic disease process. And the presenting symptoms that the patient might have, one will be a productive cough. Okay, productive cough. And the cough will be productive with foul smelling sputum. Okay, there will be copious amount of foul smelling sputum. Foul smelling sputum. In fact, very offensive smell, and sometimes the amount might be so profuse, you can call it a bronchoria. Okay, you can call it a bronchoria. So productive cough, foul smelling sputum, and yes, you may have some whenever there is an exacerbation. I told you this is a chronic disease process. So intercurrent infections can cause exacerbations. So maybe there may be fever will be there, and you may also have some systemic features because it is a long-standing illness. So some systemic features like weight loss, malaise, okay, all this will be there. And bronchiectasis, this bronchiectasis can erode into the blood vessels also, nearby blood vessels, and it can result in hemoptysis. Okay, so sometimes you might even have life-threatening hemoptysis as well. But again, the most important 2 points are productive cough and foul smelling sputum. Okay, so in a clinical scenario, you might get this. Okay, this foul smelling sputum is a hint. And always remember, do not confuse this with a lung abscess, because lung abscess is an acute process. I told you to begin with, this is a chronic disease process. So you will have a long history. So this is how a patient with a bronchiectasis will present to you. Okay, the clinical features of bronchiectasis. So what are the examination findings? Okay, what are the examination findings? So since it is a chronic systemic illness, it is likely that the patient would have lost some weight, especially if the inciting cause is a tuberculosis. It is most likely that the patient would have shed a lot of weight. He will be having malaise. But to be more specific, the important findings, one will be clubbing. So clubbing is a dominant feature in case of bronchiectasis. However, there is a type of bronchiectasis by name Bronchiectasis sicca. Bronchiectasis sicca. Sicca means dry, no? So that is a particular type of bronchiectasis where you will not have much of a foul smelling sputum, and plus you will not have clubbing, but otherwise you will have clubbing. And then you will have on auscultation, you will have coarse leathery creps, coarse leathery crepitations, which are usually mid-inspiratory, sometimes in early part of inspiration as well. Okay, so you will get all these crepitations as well. So these are the two important findings, the clubbing as well as the coarse crepitations, important findings in case of bronchiectasis. Okay, so keep that in mind. So this is how it will present to you, okay, the bronchiectasis. Now, suppose if you have a clinical scenario of a patient, so in most of the cases, they might be having some underlying pathology. Maybe he might have had a past history of a tuberculosis. When you get this question for your exam, in the background, you might get a clinical scenario of a tuberculosis, and maybe for the past, say 1 year, he has been having copious amount of foul smelling sputum, and maybe a few episodes of hemoptysis as well. Because tuberculosis definitely is not a condition where you will get copious foul smelling sputum. Okay, so then you have got to suspect, okay, is this bronchiectasis or not? Okay, so that is very, very important. Now remember, in the clinical features itself, sometimes this bronchiectasis can go in for complications. So just know regarding the complications of bronchiectasis as well. The most important complication is massive hemoptysis. Massive hemoptysis. Okay, that is a very important complication, especially when a vessel has been ruptured. And then you might have long-standing bronchiectasis, so you might develop amyloidosis. Sometimes you might develop a cor pulmonale. Okay, cor pulmonale. So these are some of the long-term complications that can happen with your bronchiectasis. Okay. Now we will see how we will investigate a case of bronchiectasis. Okay. So remember, a common question expected for the clinical scenario is bronchiectasis. So how do you work it up? See, when you want to work it up, bronchiectasis, definitely the routine bloods investigations are likely to show an increased total count, especially when there is a active infection. So increased total count, increase in the ESR, increase in the CRP. All this occur when there is an acute exacerbation, because this is often a chronic disease process with exacerbations. So when there is an acute disease process, you expect all these to be, the counts, everything to be on the higher side. Correct. And it is important that when you get a patient with a suspected bronchiectasis, you send for a sputum study. This is very important, because a sputum study, you have got to do the culture, because based on the results of the sputum study, you may require to modify your antibiotics. Okay, so definitely you have got to do a sputum study. Then you have got to do, but anyway, like just not that's the sputum, though it is a respiratory infection, I would always say that you have got to do a blood culture as well, blood culture and sensitivity, because see, this is a systemic problem that has happened. And next you have got to go for the chest x-ray. Now let me tell you, if the patient has developed a bronchiectasis secondary to an infection like say tuberculosis, then definitely sometimes the prominent imaging findings might be that of a tuberculosis. Okay, but per se, tell me, what are you expecting in a case of bronchiectasis? So in a case of bronchiectasis, this is not a pneumonia, no? So it is a condition in which the bronchi are dilated. So when you do a chest x-ray, what you are expecting is that you might see that the bronchi are actually a bit dilated. If you can see the arrow pointing here to the parallel dilated bronchi, and this particular sign where you have this dilated bronchi, that is referred to as the tram track sign. So tram track sign, remember, may be seen on the chest x-ray. It is not diagnostic, okay, and it is not necessary that the chest x-ray may show an abnormality. But if you are asked what finding are you going to look for in a case with bronchiectasis, it is going to be your tram track sign. Okay, all right. Now after chest x-ray, to confirm, okay, or the investigation of choice would be a HRCT. Okay, HRCT is going to be your investigation of choice. Okay, so what are the findings that you can expect in HRCT in case of bronchiectasis? There are some named signs that you should know of, very important. I'll just show you them. Okay, these signs in a bronchiectasis. First of all, let's see the dilatation. You see, this is the CT thorax axial section. You see here the middle lobe is showing dilated bronchi on the right side. Are you able to appreciate that the bronchi in the area that I've highlighted are actually more dilated? Okay, so this is a cylindrical type of bronchiectasis in the right middle lobe. So it is always important that the lobe of involvement also can give you certain clues, okay, regarding the etiology of bronchiectasis. So when you deal with bronchiectasis, suppose you are having a bronchiectasis predominantly involving the upper lobe. So bronchiectasis predominantly involving the upper lobe, one could be because of tuberculosis. Okay, it could be because of tuberculosis, you can have a involvement of upper lobe. Even cystic fibrosis, you can have involvement of the upper lobe. Okay, and also the radiation fibrosis. I already told you, secondary to radiation fibrosis, you may develop bronchiectasis. So all these would predispose to upper lobe bronchiectasis. But when you have aspiration, okay, because I told you aspiration can predispose to bronchiectasis. So when you have an aspiration, so that predisposes to predominantly your lower lobe bronchiectasis. Okay, a condition like an aspiration, repeated micro aspirations, and secondary infection happening. So this is usually for the lower lobe. Now for the middle lobe bronchiectasis, this is again very important. Middle lobe bronchiectasis could be because of NTM, okay, that is your non-tuberculous mycobacteria, which is well known to produce middle lobe bronchiectasis, as well as allergic bronchopulmonary aspergillosis is likely to produce middle lobe bronchiectasis. And another point that you have got to know for your entrance, it's a factual question, that I told you tuberculosis is predominantly affecting the upper lobe bronchiectasis. But sometimes, say a lymphadenopathy occurring in a tuberculosis, that lymph node can sometimes block a bronchus leading to a bronchiectasis. So this type of a middle lobe bronchiectasis associated with a tuberculous lymphadenopathy, that type of middle lobe bronchiectasis is what you call Brock's syndrome. Okay, is what you call the Brock's syndrome. Okay, that is occurring to a lymphadenopathy, associated with a lymphadenopathy and subsequent obstruction of a bronchus. Okay, so that will give you some clues. All right. Okay, coming back, cylindrical bronchiectasis in the middle lobe, and this is another syndrome that I just want to share with you. I wanted to share this because in Harrison the name of the syndrome is given, that is your Williams-Campbell syndrome. So that is another condition that can produce bronchiectasis. I am quite sure that you are able to appreciate the dilated bronchi here. Now this is one condition. The Williams-Campbell syndrome is a condition in which there is absence of cartilage. The bronchial wall cartilage, they would be absent at many places, and because of that, again, that can predispose to bronchiectasis. So that is your Williams-Campbell syndrome. Now another sign that you can see in bronchiectasis, this sign is referred to as the signet ring sign. Okay, this sign is referred to as the signet ring sign. Now what does the signet ring sign means? You will have an area of dilated bronchus which you are seeing in the red arrow. Focus on the red arrow in picture. So you can see that there is a dilated bronchus, and just adjacent to that, I'll just first highlight one for you. Okay, the white arrow pointing to, can you see something is there here? So it is adjacent to the dilated bronchi, you have a pulmonary artery. So it is almost like a ring. You agree with me or not? Almost like a ring. Okay. So this is why it is called a signet ring sign. That is another sign that you may get in case of bronchiectasis. Another radiological sign that you may get in bronchiectasis is your tree in bud sign. Okay, tree in bud sign. But again, it is not very specific for a bronchiectasis. It may be seen in numerous other respiratory conditions like your tuberculosis. So, that is not that important. So, these are the important radiological findings in case of a bronchiectasis. Important radiological findings in bronchiectasis. So, you have got to keep that in mind. So, I told you the investigation of choice is going to be your HRCT. So, you must work up for any other underlying condition, because I told you the other conditions are there that can predispose to bronchiectasis, like a cystic fibrosis, maybe a rheumatoid arthritis, a Sjogren syndrome. Even Harrison has mentioned that scleroderma also, because of the esophageal dysmotility, can predispose to aspirations. Personally, I have not seen a scleroderma patient developing a bronchiectasis, but again, it is always a theoretical possibility, because there is always chance of repeated microaspirations and development of a bronchiectasis there. Okay, so I hope that part is clear. So that means, this is how you will work up a case with bronchiectasis, and next part is that we are going to see how we will treat a bronchiectasis. How are we going to treat a case of bronchiectasis? So how are we going to treat this? So this is a chronic condition, correct? So remember that for the treatment of bronchiectasis, two most important subheadings mentioned in Harrison. One is regarding antibiotic therapy, and second is regarding bronchial hygiene. Okay, bronchial hygiene. Because the problem is in your bronchi there are lots of secretions, correct? So these two are the important points. Okay. Now the discussion on the bronchiectasis, which I am going to tell you, this will be centered around the guidelines of the European Respiratory Society guidelines of 2017. You also have a British Thoracic Society guidelines of 2019, but the discussion will go with the European Society here. Okay, so it is more of a simplified, so it is easy for you to learn as well. Okay, and also Harrison is almost matching with that. But the other important points I will be just discussing with you. See, when you want to treat a condition like bronchiectasis, this is a picture that I have taken from the same guidelines itself. So when you want to treat a condition like bronchiectasis, you have got to deal with the pathology. And I've already told you the pathology is the vicious cycle. So the vicious cycle is what you have got to intervene. And you see here, there can be various parameters that might be contributing to this vicious cycle. It may be a chronic bronchial infection. So it may be inflammation. It may be impaired mucociliary clearance, or it may be some structural lung disease. So chronic bronchial infection, yes, it could be because organisms like Pseudomonas, okay, which are very notorious to produce bronchiectasis, and they can actually have a long stay in the bronchus as well, because I am sure that you would have learned in your microbiology lessons that they are able to form biofilms. Okay, they are able to form biofilms, which makes them resistant to the action of many of the antibiotics. So it is again a tough nut to crack, the Pseudomonas infections in bronchiectasis. So you have got to deal with everything. When you want to deal with a chronic bronchial infection, you might require a long-term inhaled or oral antibiotic therapy. Naturally, because if an infection is long-lived, you have got to have a long-term therapy as well. And eradication of new pathogenic microorganisms. So I'll tell you what that sentence means. Okay, that sentence is very, very important. Eradication. I'll tell you what that means. And antibiotic therapy for exacerbations, which means even if it is a bronchiectasis that has developed sequelae to a tuberculosis, whenever there is periodic infections, maybe by another organism, say like an H influenza, you can have exacerbations. Okay. So the exacerbations may be triggered by another infectious agent. Okay. Thereby, the vicious cycle goes on and on. So if you have an inflammation that is responsible, like say a rheumatoid arthritis, so in such conditions you might require long-term anti-inflammatory therapies. In conditions where there is impaired mucociliary clearance, you might require long-term mucoactive treatments and therapies for the airway clearance. So you call that ACT, airway clearance therapy. Okay, airway clearance therapy. And if you have some structural lung disease, might require long-term bronchodilator therapy. Surgery is mainly reserved for focal bronchiectasis. If the bronchiectasis is limited to some segments, if you have a diffuse bronchiectasis, there is no point of a surgery. And pulmonary rehabilitation is also important. Okay. Just to tell you that the guidelines mainly focus on targeting the vicious cycle, and that is what you have got to target. Okay. All right. So first let me start off with in the treatment. Remember I told you I will tell you something about eradication therapy, correct? No? See, normal cases means, okay, first I'll tell you normal case and then I'll come to this eradication therapy. Normally if you have a patient presenting with an exacerbation of bronchiectasis, okay, suppose a patient is admitted with a exacerbation of bronchiectasis. In such a scenario, what you should do is that you should treat with antibiotics. You should treat with antibiotics which are given for 2 weeks. Okay, the guidelines also says 2 weeks. Harrison says 10 to 14 days, but the European Respiratory Society says it is better to give for the full 2 weeks antibiotics. So the antibiotic choice again can be dependent on the organism that is isolated. So initially you can go for an empirical therapy, and then once you get the culture results, you can switch it over. And if it is a non-tuberculous mycobacterium, okay, if it is a non-tuberculous mycobacterium, in that case you might require a treatment with maybe a macrolide plus rifampicin plus ethambutol. So always the combination of all these drugs is what is recommended. Can go for 2, but the combination of all these drugs is recommended for non-tuberculous mycobacteria. Now suppose you have started the patient on say some empirical antibiotic and you have found that this patient has got a newly diagnosed Pseudomonas infection. Okay, previously you have never got a Pseudomonas from the sputum of the patient. So you have got a Pseudomonas infection. Now if you have got a Pseudomonas infection, first thing I want to tell you is this 2 weeks might not be enough. Okay, why? Because I already told you this Pseudomonas is very well known to produce this biofilm. So it is likely to stay there and is a problem creator. Let me tell you, the Pseudomonas is a problem creator. So you want to eradicate him. It's not that you want to treat the acute infection. The word that you're going to use is that you somehow want to eradicate the Pseudomonas. Okay. So if you have got Pseudomonas, you will go for the eradication therapy. I'll tell you what is this eradication therapy. So, but I hope you understood in what context will we go for a aggressive eradication therapy in bronchiectasis. Okay. Now I'll show you the flow chart from the guideline itself. So suppose you have got isolation of Pseudomonas aeruginosa. The guideline recommends that there are 3 strategies. 1, 2, 3. Is it 1 plus 2 plus 3? No. It is either 1, 2 or 3. You can go for any of the strategies. But the common point of all these strategies is that the total duration of treatment will be 3 months. 3 months treatment is required. So just let us see, what are the treatment modalities that they suggest. You can go for a oral fluoroquinolone, that is for the initial 2 weeks. Okay. And then subsequently you can go for IV antibiotics like a combination of beta-lactam plus aminoglycoside. Then you can add inhaled antibiotics as well like tobramycin, gentamicin, colistin. Inhaled antibiotics are also recommended by the guidelines. Okay. So they are actually useful as per the guidelines, and the guidelines actually encourage us to use these inhaled antibiotics in case of Pseudomonas infections especially. And sometimes, rather than going for oral fluoroquinolone, suppose you have got a severe exacerbation, so you might require a parenteral therapy. So in that case, you go for a IV antibiotic straight away, that is a beta-lactam plus aminoglycoside. So you give it for the initial phase of 2 weeks, and then you can add inhaled antibiotics, the same ones that we have discussed. So that again is given for a total duration of what? 3 months. Or then you can go for a combination, that is your oral fluoroquinolones or IV antibiotics plus inhaled antibiotics, that is straight away. Okay. So in that case, you are going for a more aggressive therapy in the initial 2 weeks, and then you continue the inhaled antibiotics for a total duration of 3 months. Whether you select number 1, number 2 or number 3 depends on the condition of the patient and how aggressive you want to treat the patient. Okay, which is very important. Okay. Now, so you have got to be aggressive. Okay, especially on Pseudomonas infections. Now, suppose if it is any other organism that is being isolated, in that case 2 weeks antibiotic therapy is required. So newly detected Pseudomonas, you will go for a 3-month therapy. 3-month therapy. Okay, this is again very important. Now, there is a definite role, okay, very, very important role for your bronchial hygiene as well. Because bronchial hygiene means if you do not take care of that, what will happen is that all your bronchi will be plugged with these secretions. So that will again predispose to infection, and we are inviting more and more trouble as per the vicious cycle. So what I am trying to convey to you is that part also is important. So how will you take care of the bronchial hygiene? Let us see that bronchial hygiene. So bronchial hygiene, to take care of that, you can go for nebulization with hypertonic saline. Nebulization with hypertonic saline. You can go for nebulization with bronchodilators also. Nebulization with bronchodilators. Remember, steroids are not advocated in bronchiectasis. So you can go for nebulizations. You can go for chest physiotherapy as well. Chest physiotherapy. So when you go for chest physiotherapy, so it can either be a manual physiotherapy, or more commonly now in facility, if it is available, you can go for assisted devices which will help you for the chest physiotherapy. assisted devices that will help you for the chest physiotherapy. So, and also the inhaled antibiotics, okay, also are forming a part of the bronchial hygiene. Inhaled antibiotics, okay, that may also help, like a tobramycin that can help. So that is again recommended by the guidelines. So it is very important that you maintain the bronchial hygiene. Remember, you have got to hydrate the patient also well. So that is also recommended as a part of the bronchial hygiene, that the patient should be hydrated well also. Okay. So that again decreases the, it is said that if the patient is adequately hydrated, so the mucociliary clearance also would actually occur better in such patients, rather than when you are a dehydrated sick patient, the ciliary clearance also would be less. So this is the importance of bronchial hygiene in case of bronchiectasis. Okay, so I hope that is clear. Now, a patient with a bronchiectasis coming to you is definitely a patient for a lifetime. So remember that you have got to follow up the patient well, because there is always a chance of exacerbations, sometimes development of complications. I told you there can be massive hemoptysis. So if there is a massive hemoptysis that happens, suppose you have got a patient with a bronchiectasis, they are giving a clinical scenario of a patient who is having bronchiectasis, he is presenting with a massive hemoptysis. They might ask you what is the next step that you are going to do, or maybe what is the treatment that you are going to offer. So when a patient comes to you with a massive hemoptysis, definitely you have got to go for a rigid bronchoscopy, and yes, as a definitive treatment you will go for bronchial artery embolization in a patient with massive hemoptysis. Bronchial artery embolization, important. Okay. Now, what if the patient is having recurrent exacerbations? Okay. Suppose you have a patient with recurrent exacerbations. So in such a patient, the guideline says that if there are more than or equal to 3 severe exacerbations per year, then in addition to optimizing your airway clearance, and because the airway clearance therapy has to be done by a trained, experienced physiotherapist, okay, because it is such an important part of the treatment of bronchiectasis, very, very important, never to be neglected. Okay, don't think that it is just during the hospital stay of the patient that you just do the chest physiotherapy. It's not like that. It's a chronic disease. Chronic disease means it warrants a long-term treatment as well. So you have got to treat the underlying cause if there are multiple exacerbations, and if you find that the Pseudomonas aeruginosa is actually the possible triggering agent, you have to go for long-term inhaled antibiotic therapy. And in non-Pseudomonas aeruginosa infections, macrolides are the ones which are preferred, because macrolides will have the atypical coverage. So it would cover the atypical organisms also, like mycoplasma. And if there is inadequate response, you can think of combining oral plus inhaled antibiotics. Okay. So that is very, very important. Okay. So this is how you will tackle the exacerbations of bronchiectasis. So that is it about bronchiectasis. Just to summarize whatever we have learned so far, we discussed regarding what is bronchiectasis, what are the possible etiologies of bronchiectasis, how do they clinically present to us, what is the vicious cycle, and about investigating a patient with the blood studies, sputum, blood culture, chest X-ray, HRCT. And tell me what will happen when you do a PFT, pulmonary function test, in this patient. See, it is actually an obstructive pathology. So you will get an obstructive pattern. But suppose if you are having a patient with a post-radiation fibrosis, bronchiectasis, okay, after post-radiation somebody is developing fibrosis and bronchiectasis, or maybe a rheumatoid arthritis and subsequent maybe some fibrosis and bronchiectasis. In such a condition, you might get the so-called traction bronchiectasis. Traction bronchiectasis. So this traction bronchiectasis is the one which is going to show a restrictive pattern. It is going to show a restrictive pattern. Okay. So other than that, treatment we have learned the guidelines of the European Respiratory Society, but always remember antibiotic therapy and bronchial hygiene is important. And mind you, though I said the treatment of all this, it is also important to address the other causes See, suppose if you have got a cause like rheumatoid arthritis, maybe a retro infection, Sjogren's syndrome, in such scenarios you would have to address the definite cause what has triggered the bronchiectasis. Okay, so all in all, a very important and a short topic is bronchiectasis. You can expect questions, straightforward questions, they'll be very simple. Okay.